ready. Alrighty, well, in the interest of time, should we go ahead and get started? And I'll keep an eye out for Ria. But welcome everyone, and thank you so much for joining us for today's webinar called Reducing Stigma and Improving Our Work with People Who Use Drugs. Today's webinar is a collaboration between NCSD and NASTAD, and we're very excited to be working in collaboration today. So my name is Talia Parker, and I'm the Manager of Program Operations here at NCSD. And we are very excited to be sharing this webinar with you today, as we know that a lot of NCSD's members in STD programs and as DIS often work with people who use drugs. And we want to support you all with tools to reduce stigma and increase cultural competency in this work. So as Kirsten mentioned, this is a little bit of a follow-up from our webinar in April with Healthline Media on conscious language and sexual health. But today we will really be honing in on people who use drugs and drug use language. So today we will be hearing from our colleagues from NASTAD's drug user health team, the Academy of Perinatal Harm Reduction, and a current DIS from Washington State about how we can dismantle stigma and engage with people who use drugs through a harm reduction lens. So without further ado, I will go ahead and introduce today's speakers. So first we will hear from Kirsten Forsyth, who is a senior manager on NASTAD's drug user health team. Kirsten provides technical assistance to state health departments and community-based organizations to ensure the effective integration of harm reduction and drug user health approaches. Before joining NASTAD, she worked for over 6 years in Maryland at the State Department of Health and several county health departments. She is dedicated to supporting grassroots harm reduction programs while working to make public health systems more equitable and responsive to community needs. Let's see. Kirsten holds a master's degree in public health and a bachelor's degree in archaeology and anthropology. She lives in Baltimore with her new husband and a new puppy. I got those mixed up. We know where the priorities are. And this is perfect. It looks like Ria just joined us. Thank you so much for joining us today, Ria. I'm just going through introductions now and was just about to get to you. So Ria Sinas lives in Portland, Oregon with her 6-year-old daughter, Lola. With over a decade of frontline experience, Ria works tirelessly to push back on antiquated narratives about drug use and parenting. Her dynamic and unique blend of equal parts harm reduction professional and drug war survivor posit her to create grounded yet innovative solutions to complex problems. She is the co-founder of the Academy of Perinatal Harm Reduction, a benefit LLC whose mission is to improve the lives of pregnant and parenting people who use drugs. She has worked in both the public and private sectors of syringe access, as well as in housing first and low barrier emergency shelter services. Ria was co-chair of the National Perinatal Association's Family Toolkit Work Group and co-chair of the 2018 Conference Planning Committee. Ria's work has been highlighted in publications such as Undark, Filter, Narcotica, The Daily, and countless others. She is a peer reviewer of the American Journal of Public Health. Ria has spoken at dozens of national conferences as an expert in perinatal and reproductive harm reduction. She's a guest lecturer for Cornerstone Birth Workers on harm reduction and integrating it into doula practice. Most recently at her organization, in partnership with the National Harm Reduction Coalition, published the first ever harm reduction toolkit for pregnant and parenting people that use drugs. And when not working, she spends time with her daughter. Together, they love going on outdoor adventures, listening to musicals, and cracking sarcastic jokes. And a long, long time ago, she used to be a Southwestern archaeologist. Wow, we have an archaeology theme running along here. And last but not least, we have Libby Harrison, who will be presenting. Libby started working in harm reduction in 1995 as a volunteer for Danzine, an agency created by and for sex workers whose mission was to improve the health and safety of those working in the industry. Libby worked in the sex industry for 8 years. She has continued with a variety of harm reduction work that has included outreach, education, prevention, and research. The population she has focused most of her attention on are people who inject drugs and people engaging in sex work. Fun fact, her favorite job to date was as a sex educator for youth in Cincinnati, Ohio. Currently, she is a disease investigator for the state of Washington, focusing on hepatitis C. Thank you all so much for joining us today. I also forgot to do a quick housekeeping note. So today's session will be recorded and shared after the fact. If you have questions for the presenters, and I hope that you do, we will have plenty of time for Q&A at the end of the session. Please feel free to put your questions in the Q&A box or the chat, preferably the Q&A box though, so we can keep everything organized. So with that, I'm going to hand it over to Kirsten to start us off today. Thank you again for joining us, everyone.
Thanks so much, Talia, and thank you to NCSD for hosting this webinar and for partnering with NASTAD on this work. I'm really excited to be here today with my co-presenters, both of whom probably have about double the amount of experience that I have in harm reduction, so really among good company here. Next slide. So just a little bit about NASTAD first. Many of you are familiar with NASTAD. We're a nonprofit national association founded in the early 90s. We represent public health officials who administer HIV and hepatitis, and more now drug user health programs funded by state and federal governments. Our mission is to advance the health and dignity of people living with and impacted by HIV, viral hepatitis, and intersecting epidemics. And we do that by strengthening governmental public health and leveraging community partnerships. Historically, NASTAD has worked with health departments, and we still do that, but especially on the drug user health team, we have the opportunity recently to work more directly with community-based harm reduction and syringe services programs. So that's been a really crucial part of our expanding work. Next slide. So just a few general learning objectives for this session to kind of signpost us all for where we're going to be going. We're hoping to share some strategies for engaging people who use drugs using a harm reduction approach. We'll talk about the impacts of drug-related stigma, particularly on health and on accessing healthcare services, and some of the ways that we can all work to counteract stigma. And then we'll talk a little bit more about the intersection of drug use, sex work, and reproductive health. These are all kind of, huge, very broad topics, and this training could last for hours and hours, but this will just be kind of a little introductory kind of foundation setting session. Great, so just to ground us all a little bit in the data, I know that many of you work in sexual health and in infectious disease, so are probably quite familiar with this. In the United States, we see that injection drug use accounts for about 1 in 15 new HIV infections and over 72% of Hep C cases. And injection drug use is a risk factor, obviously, for HIV and Hep C transmission, and particularly for Hep C, which is really prevalent among people who inject drugs. The statistics tell us that 60 to 90% of people who are injecting drugs will have hepatitis C within 5 years of initiation. Median time to infection is about 3 years. And every year we have 20 to 30% of the population of people who inject drugs are infected or reinfected with Hep C. Next slide. So a little bit more about Hep C, because it is such a prevalent issue among people who inject drugs. And particularly, we've seen recent significant increases among young people. So the kind of 25 to 35 age range, 25 to 45, we're seeing much higher rates of Hep C in those populations. And that's primarily due to increases in injection drug use. About 85% of Hep C infection will progress to chronic infection. Injection drug use is the most common risk factor, and it's the leading cause of death among all infectious diseases. And one piece that I really want to point out that's critical to the rest of our conversation today is that these risks are due to restricted access to life-saving supplies, such as sterile syringes and other injection supplies, not necessarily due to drug use itself. So, there are many harms that are associated with drug use. With a harm reduction approach, we're focused on, what what we control and what's within people's behavior in order to reduce their risks. And one of those is being able to use more safely by accessing sterile supplies. Next slide. And just to add to this, it's not just HIV and Hep C that we're talking about. We're talking about a range of other bacterial and viral infections that are associated with injection drug use or are more common among people who inject drugs because of the various sort of social and environmental risk factors that they're exposed to. So all of these infections can also be prevented by providing people the supplies that they need, primarily sterile syringes. We'll hear more about sort of, syringe distribution and syringe services programs later on in the presentation, but just underscoring the fact that although we have service provision in this country, it has never been enough or resourced well enough or have enough coverage to get the full benefit of prevention of bacterial and viral infections that we could from this intervention. Next slide. Great. So I've talked a little bit about harm reduction already, and I want to just give us a basic definition. I imagine that most people listening have heard of harm reduction. Some may be very familiar with it. I saw some folks from syringe services programs and have worked in harm reduction for a long time. So there can be a lot to unpack around harm reduction and its history, but at a baseline, we define harm reduction as a set of practical public health strategies designed to reduce the negative consequences of drug use and promote healthy individuals and communities. These are some of the principles of harm reduction listed here. There's a real emphasis on dignity and respect for people who use drugs, each individual having the right to health. There's a real emphasis on creating services that are participant-centered and are responsive to the needs of actual people, not based on any kind of judgments or assumptions that we might make from our program implementation or service provider role. We understand sort of the broader social and cultural complexity surrounding drug use, but also try to take a really pragmatic approach that's responsive to what people are actually experiencing on the ground. Next slide. So harm reduction programs promote drug user health in a variety of ways. Some general principles are that programs provide services to people who are actively using drugs without the expectation that they stop. So there's no sort of abstinence requirement before someone is able to engage with a service. Provide supplies and resources to empower people to live as safely as possible. Prioritize non-judgmental, non-stigmatizing, non-coercive, strengths-based, and mutually respectful engagement with people who use drugs. And importantly, acknowledge the harms associated with drug use, as well as some of our policies around drug use, while also presenting accurate information to help people reduce harms. Great, so let's get into this a little bit more. I think before we talk further, it's important to just recognize that the people use drugs for a variety of reasons. We've listed some of those reasons here. I'm sure there are other reasons that folks could come up with, either from their own experience or from friends or family or others that they're familiar with. So people use drugs because they're curious, because they're trying to manage pain, because they have a substance use disorder and are trying to avoid withdrawal, to relieve stress. I think most of us probably had coffee this morning or some other kind of caffeine, might have a drink later on to wind down from our day. So lots of different reasons that people use drugs, and a distinction that I want to make is that not all people who use drugs have a substance use disorder, which is a diagnosable condition with certain criteria. So again, trying to understand the real breadth of what drug use can look like and not make assumptions about someone's relationship to a substance. So putting this kind of another way, the arrow on the left is how we, I think, usually visualize drug use, sort of how, the messages that we get societally and culturally tells us that drug use is linear, especially illicit drug use. So drugs like, heroin, crack, cocaine, someone uses one time and then they might be hooked for life, or the use will continue to escalate forever and ever into problematic space. But actually, drug use looks a lot more like the squiggly line on the right. So people can move in and out of relationships to different substances. They may use one substance chaotically or problematically and use another in a non-problematic way. People will move through different phases of their lives during which they're using substances in different ways. And often that has to do with sort of the social and environmental context of someone's drug use. And that's what we're going to look at a bit more in the next slide. So one theory that we find helpful in thinking about drug user health and in harm reduction is the drug set and setting theory. And this was developed by Norman Zinberg and sort of expanded upon by other researchers since. But this came out of some studies on drug use and substance use disorder in the 70s and 80s. And Zinberg found that there are 3 major factors that can shape drug use behavior. And that is the drug, so the type of drug, the amount, the route of administration, the frequency of use, the set or mindset or attitude toward drug use, so sort of what's going on within the individual, and then the setting, the context in which the drug is being used, where, when, with whom, even factors such as is someone using alone, or are they in a group? Is that group sort of antagonistic, or maybe there's the potential for conflict, or is it a supportive group setting? So again, kind of thinking more broadly about how and why people use drugs and how that might contribute to some of the risks that they experience. And sort of continuing in that vein around the context of drug use, many people are aware of the social determinants of health. So the social determinants of health are social, economic, and political circumstances that influence individual and community health status. So that can be everything from at a community level, lack of housing, availability of substances, availability of other resources, at the structural level, racism, poverty, access to education, sort of what level or quality of education people have access to employment as well, and the circumstances of that employment, and whether people are able to meet their economic needs. So within a harm reduction framework, we have the level of an individual, and we're looking at their own relationship to a substance, the risks they're experiencing, and the ways to reduce those. But we also have a responsibility as providers to acknowledge these wider barriers and these wider circumstances that make people more or less likely to experience problematic substance use or to intensify risks around drug use. Okay, let's talk a little bit about stigma. Just a general definition here. Stigma is a set of negative and often unfair beliefs that a society or group of people have about something. Could also mean a mark of shame or discredit. The word stigma initially came from both a Greek word and a Latin word that actually meant a physical mark or a brand. And that was used several centuries ago to identify someone who was a criminal or a slave or otherwise kind of, marked as morally reprehensible. And then that physical mark would separate them from society. We also see the roots of stigma in the word stigmata. So think about, Jesus and the physical wounds resulting from crucifixion. So this is the origin of the word stigma. These days, it's not so much used to represent a physical mark, but more a sort of symbolic category that we put people in, that consists of labeling, stereotyping, separating groups of people from the rest of sort of mainstream society, resulting in the loss of status and ultimately discrimination. So stigma is sort of the belief that underlies the action, and discrimination is the action that results from stigmatizing beliefs. Next slide. And stigma is based on social control theory, the Puritans. This is a social process that reinforces relations of power and control. So stigma needs to also be understood in terms of understanding power dynamics. And generally, sort of groups that have more social or economic power are more able to stigmatize and therefore discriminate against groups that have less social or economic power. And stigma is intersectional. So people can hold multiple stigmatized identities at once, and that will equal an entirely new experience of stigma, right? So thinking about someone who's stigmatized for using drugs, that's one type of stigma. But if we think about, say, a Black woman who's using drugs, then there's also maybe racism and sexism or misogyny compounded onto the stigma around the drug use. Stigma can take several different forms. So it can should be played out individually in interpersonal relationships. Stigma can be baked into our institutions through policies and laws. Stigma can be internalized or taken on by the individual or group being stigmatized, or play out by association. So for instance, family members who are stigmatized because of their association with a son or daughter, or another relative who's using drugs. Let's go to the next slide. Okay, so stop there. Thanks, Talia. So I just wanted to look at a few, sorry, I have a puppy below my desk. So I'm like trying to manage that at the same time. The puppy is getting a lot of education on drug user health and stigma at the moment. So looking at some common myths that we hear and that are reinforced culturally in the media, lots of different places about people use drugs. So you always know that someone is using drugs. An addict will always be an addict. Again, sort of that stigmatizing language there, an addict, and whatever that we've been taught that represents. Abstinence is the only real recovery. Using medication as treatment means you aren't really recovered. And these are really entrenched messages that, without realizing it, I think many of us have grown up hearing. It takes a little bit of examining that and, building up our own ideas and experiences that can replace these beliefs that aren't true. So can you show the facts side? Great. Thanks, Talia. So many people use drugs and you'd never know. People, again, like we talked about earlier, may transition from chaotic to benign use. There's some research actually that many people who use drugs sort of age out or spontaneously recover from substance use without having received intensive substance use treatment. So that's something to consider as well. Recovery can include abstinence, but it can also look differently. It can look a lot of different ways. And medication-assisted treatment, that's MAT, or medications for addiction treatment. Some people say medications for opioid use disorder. There's different ways of describing that, but it's evidence-based and it's considered the gold standard. Many people have chronic conditions for which they use medications long-term, for decades or for the rest of their lives. And if in many ways we are trying to treat substance use as a public health or medical issue, then we need to accept the evidence and the importance of medication. Next slide. Okay. Yeah, so let's stick with this one. Again, just thinking a little bit more about stigma and the intersectionality of stigma. Here are a few examples. They're a little bit dated, but hopefully these are well-known public figures who have struggled with drug use. Here's a quote from the media about Whitney Houston and her death. It says, "Let me break down this autopsy for you. She had a perforated nasal septum. That's where the septum dissolved from so much coke. Long-standing chronic use of cocaine, chronic emphysema, fatty liver, which means she drank a lot. So the idea that she had a heart attack, let's be real." So we have a quote from Amy Winehouse. You can go ahead and show the rest of the quotes. So just thinking about that Whitney Houston quote for a moment, this is virtual and we don't have the ability to kind of interact, but if we were, together in an in-person session, I would ask, like, what does that bring up for you? What does this quote kind of say about the judgments and assumptions we're making about Whitney Houston and her drug use? It's pretty dismissive. It's pretty kind of blames her. Doesn't take seriously the fact that there may have been an underlying health issue or that actually her death, wasn't ruled a suicide ultimately. And then let's contrast with that with, say, the Heath Ledger quote. "Still, part of what made Ledger such a passionate, curious actor, capable of reaching extraordinary emotional depths in his work, is inextricably linked to the sensitivity that left him vulnerable to addiction and shutting himself off from others, many of whom tried to help him." Right, so a pretty big contrast there. In that quote, drug use is talked about as sort of part of his creative process. It's talked about in a sympathetic way. He's just so emotionally deep and so vulnerable. They talk about others who tried to help him. So he's described as a person who was worthy of help, but just couldn't be reached. And this is such a tragedy. So I won't linger on these for any longer, but just to kind of illustrate some of the ways that the stereotypes and the stigma is reinforced through the media and how different it can look depending on race, class, gender, etc. So stigma has a number of impacts on health. There is the fear of judgment, which limits willingness to access care and services. I've known many people who, might have a wound or have another health problem, but don't want to go to the hospital because they know they're going to be treated poorly. The internalization of stigma affects people's personal view of being worthy of services and can create an identity associated with that stigma. So, that's just not something we do. We don't go to the hospital. We don't go to the doctor. A reluctance to associate with people who use drugs can reduce support systems. We have that belief sometimes that someone needs to hit rock bottom, or that we can't, maintain connections with people who are using drugs because that would be enabling. And all of that acts to sort of, reinforce stigma, reinforce disconnection from services, and in turn, create increased risks for people who use drugs. And then we have discrimination in services. So we see that particularly in Hep C treatment. That's top of mind for me in terms of sobriety restrictions, doctor bias, other policies that make it difficult for people who are using drugs to access Hep C treatment, even though we know that they can and do adhere to Hep C treatment and can be cured at similar levels to the general population. Next slide. So I need to mention drug policy and in particular, the racism inherent in our country's drug policy and its impacts on health. And I know you'll hear a little bit more about this from Ria later. But our global and US drug policy is focused on criminalization and interdiction to reduce supply and demand for illicit substances, often at the expense of investing in health and social services to keep individuals and communities safe. So early drug policy was used to target communities of color over and over again, starting with sort of anti-opium laws, targeting Chinese immigrants in the early 20th century on through. This has led to discrepancies in who has access medically to certain substances or medications versus who has to turn to illicit access. The war on drugs has been used to escalate mass incarceration and to cut social services and programs, and a whole range of other sort of knock-on effects from this drug policy: abstinence-based drug education, treatment that is not based in the evidence, criminalizing paraphernalia, limits people's ability to access the resources that they need to keep themselves safe. So I think we've moved from our initial definition of harm reduction, which is a set of practical public health strategies designed to reduce risk, to a bit of a broader conception of harm reduction. And this quote is from Imani Woods, a sort of an original harm reductionist in the 80s in the US during the AIDS crisis. She says, harm reduction is a form of social justice. That's all it is. It really ain't that complex. It's a form of social justice that talks about quality of life for each and every individual, period. It's just that simple. So yes, it's the practical public health tools and the programs that we implement, but it's also sort of a philosophy and a belief in social equality across different groups of people. Next slide, please. Okay, I want to focus in on this piece because it's about sort of what we can do as individuals and at an organizational level to reduce stigma. And I think most folks joining the webinar work for health departments. Even if you don't, these recommendations are still useful for whatever setting you might be in. At the individual level, using person-centered language. And we're going to talk about that a little bit more. So we'll give some examples of person-centered language. Building relationships with community members, with harm reduction programs, knowing where your local syringe services program is and how to access it. Building relationships with service providers in order to help them better understand what clients need, especially clients who are using drugs. Allowing the space for discourse and dialogue, and encouraging and pursuing education and personal development, which is what we're doing here. At the organizational level, we want to pursue intentional hiring practices with an emphasis on hiring people with lived experiences. And that can mean a range of different lived experiences. So lots of different kind of vantage points are helpful in doing this work. That might mean hiring people who are actively using drugs. It might mean hiring people who recently used drugs or are in recovery and had a history of using drugs in the past. It might mean people with experiences of incarceration or in the criminal justice system, experiences of HIV or Hep C. So that can look a lot of different ways, but we need to prioritize folks with lived experiences in our programs and including in the leadership of our programs. The other one I want to highlight here is creating multiple avenues for feedback, including meaningful opportunities for client or patient input. So for a lot of syringe services or community-based programs, that could look like a community advisory board. There are many sort of formal and informal ways to do that. We're happy to chat with anyone afterwards about different ways to create opportunities for feedback that sort of respects and prioritizes the client voice. Next slide. So what do we mean by person-centered language? So the definition here is linguistic prescription to avoid marginalization and dehumanization regarding a health issue or disability. So sometimes this means person-first language. That might be a term that some of you have heard. So speaking about the person rather than about their behavior or about a label that describes a person. So you hear me say person who uses drugs, a person with a disability, a person who engages in sex work. So we're putting kind of the person first, as the term says, and then describing whatever behavior it is that they engage in. It can be a little clunky, but it feels better than kind of labeling and stigmatizing people and not sort of really understanding if what you're saying might be offensive. A few other best practices. So not describing people by their illness, by their disability, by their drug use. Recognizing the complexity and the many identities people have. Just because someone has come to you and that they use drugs doesn't necessarily mean that that's their priority on that day or that they don't have many other identities that are equally important. Not using morally loaded descriptions when describing someone. So like dirty or clean, those can be very stigmatizing terms, implying that if someone's clean, then in the past they were dirty. Even sober is, some people like the term sober, and some people would rather say, currently using drugs, not using drugs. And there's a wide range in terms of how people self-identify. So we also need to make space for, if someone comes into the SSP and they, say, I'm just a junkie or whatever it is, like, I'm not going to police the language that that person is using for themselves. But as a service provider, I'm not going to use it. Avoiding other sort of language that describes negative states. And really trying to be precise about our language, especially in sexual health, where the important thing is not to sort of label someone, but to understand what behavior they're engaging in and what risks might come with that behavior. Next slide. Okay, I might skip this one and I'm going to go to the next one because I'm just mindful of time and I want to make sure my other co-presenters have plenty of time. But I do want to touch on the personal autonomy, which we saw as one of the principles of harm reduction. This is an individual's capacity for self-determination or self-governance. So being able to determine one's own course of action in life and having those decisions respected and honored. And working with people who use drugs really requires respect for people's choices. It might not be the choice that you would make, but it is essential to respect people's choices. And I would add to that, again, going back to the social determinants of health and the sociocultural complexity around drug use, recognizing that people are making often the best choices they can within limited circumstances. So, many people are doing probably much better than I would be in their position. People are doing the best they can with the cards that they've been dealt. And we need to have respect for that and understand kind of where people are coming from. Next slide. Radical neutrality. I love this concept. I think it's a very difficult one, but that's okay, because we can always be becoming better harm reductionists and better service providers. We don't have to be perfect. So providing these services requires a willingness to practice radical neutrality, grapple with ethical gray areas, tolerate, accept, and understand difficult behaviors, be taught by our clients, relinquish the role of authority, judge, or expert, and partner with clients. So this is back to the kind of harm reduction principle of collaboration, mutuality, and it kind of upends the traditional, healthcare provider-patient relationship. This is about, not coming at people from a kind of hierarchical lens, but really seeking to kind of understand, accept, and partner with people. Next slide. All right, so this is my last slide, and I just kind of want to put it all together and emphasize that what we need for people who use drugs is a comprehensive approach. This can and does include substance use treatment, particularly medication-assisted treatment, but it includes a range of other services as well. HIV and Hep C testing and treatment, so infectious disease-related services, including, STD, family planning, reproductive health services, PrEP for people who are using drugs, a range of other harm reduction tools, naloxone, syringe services programs, mental health services. There are many actually that aren't on here that could further make up our comprehensive approach. So thinking about housing and just to kind of illustrate the breadth of needs that people who use drugs have, and not to sort of just focus on making judgments about whether someone has a substance use disorder and what kind of treatment they need for that, but to think a bit more holistically about what people want and need. So I'm going to pass it now over to Ria. I know I went through that a little bit quickly, but I saw lots of comments in the chat. I love that, and hopefully we'll be able to come back to some questions later on.
Can you shut the door when you're way out? Hi everybody. Thanks, Kristen. Am I controlling the slides, or is somebody else doing it?
I am doing the slides, if that's okay.
Okay, great. All right. Well, that was an awesome setup. I think a lot of what we'll touch on is just a bit of a deeper dive into everything that you've already talked about. So, yeah, I think in framing the conversation, just talking a little bit more about the drug war and sort of its roots, and how that's impacted specifically women or people who identify as women, and their interactions with service providers and sort of the medical world in general. So the earliest sort of international drug policy that carried out into what has now become our drug policy was at the Hague International Opium Convention. And really, it was sort of, this treaty was signed, countries deciding what their approach was going to be towards anyone who was distributing or manufacturing basically opium, cocaine, and harder drugs, and all of those drugs were generally associated with different racial groups. And whenever we see throughout sort of drug policy history, whenever we see changes in drug policy, it's sort of aligned with industrial expansion or a need to sort of control women's reproductive health. And so that after the Hague International Convention, then we had the Harrison Tax Act, which was like the first in the United States, the first real drug control policy that was created. And it was targeted Black, Hispanic, and Chinese folks. And really, as all prohibition does, created a Black market for substances, which then made them more dangerous. And so, explicit racism and blatant racism was sort of became the pervasive thought. So what people would think about folks who consumed cocaine, they're automatically connected or thought to be associated with Black folks. And those who consumed opium were, associated with the Asian population. And then sort of just going straight into the Scheduling Act, or the development of scheduling and the DEA in 1970. And this is really when, prescribers and the medical industrial complex, for lack of a better term, started having more of an interface with people who use drugs. Next slide. So as we talked about, the war on drugs is a war on people of color. I'm sure you've heard of, a huge explosive prison population, largely consisting of people of color and people incarcerated for low-level drug offenses. African Americans are more likely to have convictions involving police misconduct that results in exoneration. And another interesting fact is that people who use drugs, along racial lines, white folks and people of color use drugs at the same rates, but people of color are incarcerated at higher rates than their white counterparts. Next slide. But really, the war on drugs is a war on women and children. This is important because if we think about substance use disorder, because it's important to recognize that not all people that use drugs have substance use disorders. Some people have very healthy relationships with substances and live perfectly normal lives. I think most people have had a morning cup of coffee this morning. That's a substance. All of the research points to trauma as being sort of the foundation in which substance use disorders are born. And so as a result of our drug policy, women are a very fast growing population of those incarcerated, and they're incarcerated for nonviolent drug offenses. What's astonishing is 3 to 10% of women admitted to prisons and jails are pregnant, which is, you have to think about family systems and how that impacts them. And more than 60% of incarcerated women have minor children. Next slide. Why is it that people who use drugs have a hard time, specifically women have a hard time, or pregnant people have a hard time, or might be reluctant to access services or engage with medical providers? Well, that's because of the sheer fact that, substance use during pregnancy is criminalized. And so there's, as you see here, there's 24 states plus DC that's considered, substance use is considered child abuse. And there's all sorts of crazy laws and cases that have recently come out where, if a person has had any substances in their system during their pregnancies, and for whatever reason results in miscarriage or preterm birth. There's no, correlation does not mean causation, and there's no way to prove that substance use was a direct reasoning for these negative impacts, and yet women are held responsible and prosecuted and for those negative outcomes, which is kind of a scary thing to think about, because if anything goes wrong during a person's pregnancy, you could be held responsible for that. We try to encourage people to get into treatment, but yet we don't have any, we don't have places for people to go to access treatment. So it's sort of this double speak that happens. Next slide. So Kristen talked a lot about stigma before. I think it's interesting because historically, women were largely ones that consumed, at the Industrial Revolution, women largely consumed or prescribed opiates for all sorts of different ailments. People were, I'm sorry, I'm a little nervous. So women were prescribed, largely consumed most of the opiates that were being prescribed during that time. But, okay, next slide. I think one of the things to really consider is that stigma, our own culture and our own personal attitudes around drug use as service providers largely inform how we treat other people. And so if we're thinking about how service providers are going to engage the population or improve services, the only way that you're going to be effective is by interrogating your own bias. And we talked about stigma and drug use, just in general. But I think, that if you're a pregnant person who uses drugs, or if you're a person who engages in sex work, survival sex work, and uses drugs, those are some of the most marginalized groups of people, even within the harm reduction community, and largely, underserved, and a lot of them need a lot more, require a lot more services and more compassionate care and trauma-informed care. And that's only going, that population is only, you're only going to be able to serve that population of people if you interrogate your own bias. And we're surrounded by it. I mean, everywhere we look in our culture, we have to grapple with what it means to be a woman, what it means to be a parent, we're inundated with images of we had the crack baby epidemic in the 80s, then was Oxytots, and now it's like meth moms, and so it will just continue to just keep cycling. Next slide. And so as a society, this is how we see women who use drugs. Next slide. But we other people, but we see our own drug use as being, like upper middle class, not, we're not like those people. We're not in the alley with a syringe in our arms. And so, holding those attitudes and being ill-informed about the reasons why people use drugs. I mean, I think one really big important thing to highlight is just remaining curious. Like, if you're working with people, have a curiosity. Don't make assumptions about what that person's life is like, or why they use drugs, or why they're even coming in to engage with you. I think remaining curious is super important in terms of building relationships, and really that's all that this is all about, is building relationships with people. Next slide. So yeah, we just talked about that. Go ahead and skip forward. I just want to highlight something that's really kind of wild to think about when we think about the medical model of substance use disorders. There's sort of two kind of ideals. There's a medical model and the biopsychosocial model. In the medical model, we kind of look at substance use as a medical condition that's based in genetics, chemistry, and biology, but then we're in the same breath, we're told, and we like believe as a culture, that people who use substances are untrustworthy, manipulative, and unable to make decisions. So, you know, which is it? Like, is it a medical condition, or are people of their own volition behaving this way, trying to get something out of you? And if you believe that way, then you're going to have a really hard time engaging with the people that you serve, or people coming into clinic who use drugs. Next slide. And so think about this, right? Substance use disorders are the only medical conditions for which dependence and intoxication are not illegal, but possession of a drug is. It's the only medical condition where a special class of crimes has been created for pregnant people. It's perfectly acceptable to discriminate against a certain group of people because of these substances. It's the only medical condition for which medical providers routinely collect criminal evidence against their patients, and having the condition is a reason to withhold medical care. So persons trying to access medical care, but they're told, well, you have to stop being sick with the thing that you're sick with before we can get you help for it. It's pretty, it's outlandish, really. Yeah, and abstinence is often a condition of accessing care, and it's the only medical condition where your employment, housing, parenting, and social services can be taken from you. So next slide. We talked a little bit about language earlier, so I won't go through it because I want to be conscientious of time. But really, when you think about when you're thinking about language, think about the fact that, like, what are the questions I'm asking, are they important? How do they frame the conversation? How is it going to better the relationship? And are the words that I'm using useful? Do they describe the behavior or the condition? Are like using person first language, separating the person from the disease or disorder, and are they empowering, like the words you're using, or are they diminishing? Do they make a person feel small, or are they hopeful? Those things, the way that we talk about things frames it frames policy, and unless we start changing our language around this stuff, it's not going to change. It's not going to change on the larger scale. Next slide. I said before, not all people that use drugs have substance use disorder, but that doesn't mean that we shouldn't act as if they haven't had some sort of trauma in their lives. And so, being trauma informed, it's like, I don't think that we have to ask people if they've been traumatized. I think just being born is enough, like, to know that we're all sort of walking around traumatized. But more than 2/3 of children reported having at least one traumatic event by the age of 16. So, like I said before, if trauma is the prerequisite for substance use disorders, then it's safe to say that we're all traumatized, and the fact that we probably have struggled with some kind of compulsive behavior. And so using that framework in which way to approach your patients or clients is important. Next slide. So we talked about risk factors before. Kristen talked about risk factors before. I think one thing to really think about, take away, is that historically, PrEP has been used or marketed towards men who have sex with men. However, and for whatever reason, I don't really quite understand, injection drug users are a perfectly good population to to prescribe PrEP to. And it's interesting because I do testing in my work. I work at a syringe exchange and a federally qualified healthcare center here in Portland, and we do testing, and it's really amazing the number of people who inject drugs who have never heard of PrEP. So, but it's not just drug use that creates risk factors for HIV and other STIs. You know, it's just not using condoms, and then you know, engaging in the sex trade. Next slide. I just wanted to point out the fact that, like, we're working with a population of people within the reproductive age or the reproductive span. And so Dr. Mishka Turplin came up with this really cool, I guess, diagram called the pregnancy box. And so it's like we're moving along of the reproductive life course, and that intersects with substance use. So you know, it behooves people to inform themselves about drug use and become knowledgeable about it, because especially if you're working in reproductive health, because those two things are intersecting with each other. Next slide. Yeah, so, you know, something that's, you know, effective, shared decision making, you know, harm reduction is all of the things that Kristen mentioned, but it's also, you know, being a steward and not having power over. It's building a relationship with the person that your clients or participants or whomever, and sharing in the decision making process, because ultimately they're the ones that are going to be deciding which direction or their treatment plan. They're either going to do the things that are outlined or not. And so the more buy-in, you'll have more buy-in if you're working with your patients and supporting their goals and asking them what their goals are, instead of you kind of telling them what their goals are. Next slide. I don't know what. And then I'm sure our next presenter is going to talk much more about the sex work stuff than and be much more knowledgeable than I am. But just one thing to think about is, like, also, you know, being supportive of sex workers by being knowledgeable about harm reduction strategies as they're related to sex work. So bad date lists, peer supports, drop-in groups. And then there's a link that I provided to this really awesome, I guess it's a booklet called Tricks of the Trade that Berkeley Mead put out. And it's basically harm reduction, practical harm reduction advice for sex workers. So, you know, having information available, readily available. Next slide. So harm reduction in action, what that looks like is all of these things. And, you know, nutrition, transportation, like if you're wanting people to be successful in like being adherent to medication, or, you know, getting tested regularly, or, you know, or changing behaviors around their sexual practices, well, they have to be able to get to clinic, right? So like being able to provide them with transportation, very, very useful, very important. You know, care coordination, like, you know, maybe people they'll be more likely to engage with reproductive health stuff if they're, you know, if they're not having to worry about their housing. So, you know, I think reimagining what we can do, you know, what healthcare looks like, and integrating those social determinants of health into our practice. You know, I don't know why things are so separated, but people, you know, we're not single issue people. So we, in order to engage in our health, we have to be, you know, we have to eat and have a ride and all of those things. Next slide. I just kind of said that before. Next slide. So I just like, these are sort of theoretical things to think about, but, you know, we're sort of dreaming up this new framework and context in which to think about harm reduction and reproductive health. And I call it just reproductive harm reduction because, you know, the reproductive justice movement, you know, rightfully was, separated themselves from the harm reduction movement because of skepticism, because of trauma, and so we've sort of integrated a lot of those ideas into our ways of thinking about reproductive health within harm reduction. And the harm reduction community has really done an awful job at integrating reproductive health. So we need to like marry those two things together and have these types of conversations that we're having right now. Next slide. I'm sure everyone's familiar with reproductive justice. We don't need to talk too much about that. Next slide. Again, we can go over that. Next slide. So what do we do about it? Like I said before, we have this evidence about efficacy of syringe access programs on drug user health, and the framework that our sisters from the reproductive justice movement built. And so now we can sort of create this new movement called reproductive harm reduction. And I wanted to just touch on something really quickly that Kirsten mentioned before about, making sure that we're providing space for peers to be involved in service delivery or advisory boards. And I think those things are really powerful, but I think if you're going to do that, you have to also create space for mentorship and leadership capabilities within your organization, and not exploit that labor and that expertise, because I've far too often, I think peers and advisory groups are scary too, because they can be, because a lot of times it can be, for some people, checking a box and sort of getting an echo chamber of what a group of people echoing the desires of your organization. So making sure that that's a really authentic advisory committee, but and also giving those people real opportunities to succeed and have not just a seat at the table, but like setting the table and inviting others to that table as well. Because, your peers and people with lived experience have knowledge and expertise that you will never have. And they that should not be exploited. I just wanted to say that. Next slide. That's all.
Thank you so much, Ria. We'll move to our final presenter now, Libby, and then we'll come back to questions at the end.
Are we there?
Yes.
Okay. Hey, everybody. So my name is Libby Harrison. I've been doing this work for a while now, and I currently work for the Washington State Department of Health, but I am actually speaking just as me. I am not speaking for the state of Washington. So Kirsten covered a lot of what I would cover, but I do want to hit one point that she said over again. Please, can we get rid of the word clean? I mean, seriously. When I used, yes, I was dirty, but not because of the drugs. I just could have showered a lot more. So using that language, the clean, dirty, and that alcohol gets its own of sober, we really got to change that. It's insulting. No other group would be okay being called clean or dirty. All right. So beyond that, talking about language that we use at the exchange or the SSPs, it's really important to meet clients' language. And I think for a lot of us, that seems very natural. But the place that we don't do it is we have been taught to talk to people, like when we put out our publications, it's this write it at, what is it, like fourth grade level. And sometimes we communicate that way. And our clients are smart. And we have a tendency to talk down because we want to make sure nobody's missing anything, which is awesome. We don't want people to miss anything, but making I am okay with throwing myself under the bus and saying, you know what, if I get going too fast, if I say something that doesn't make sense, just stop me. I have a tendency to do that. I have a tendency to overgo. And then that gives that person the ability to stop and say, actually, I know what you're talking about right now. Like, I know where the femoral vein is. I know not to share works, whatever it may be. But giving people the room to be intelligent, because a lot of times when we're talking to folks, we drop it to the lowest level we can so we don't miss anybody. But what happens is people stop listening when they feel they're being talked down to. So don't be afraid to use language that seems more technical. Try to match the client's language. I'm not saying at all times is that appropriate. I'm not going to use derogatory terms that they may use for themselves, but I'm going to try to match what they're saying. And that will reduce some of the stigma that we're putting on folks about what their education or their understanding of things are. And when talking like matching language and bringing folks in, and we wanting to be able to hire from within the community, be whatever community that is, there does become I just lost the word. Basically, when we're hiring peer navigators, which is not a term I love either, but I'll get to that in a second. When we bring people in, they have a tendency to stick with the language that they know. They're part of that community. And that is why we are hiring them. And that is wonderful, except not everybody from that community knows that they're part of that community. And so working with folks that we're bringing in and want to be the front line and want to be truthfully the head of these agencies, teaching them to remove themselves one step. I know I love, like, even though it's been years since I put a needle in my vein, I still refer to that time period. I'll still call myself a junkie. I cannot use that language at an SSP because people don't know that that's my history. They don't know me. And so working with the peer navigators that we're hiring to teach them how to come across to everybody. Because if they're speaking one way with their population that they know and maybe they've used with, but then they take that same language and put it with somebody who doesn't, that new person, that different person might be highly offended by the language being used. So it's about reshaping people's dialogue and teaching them this is how we have to present, because we're now standing on this side of the desk. And on this side of the desk, we have to make sure that everybody is comfortable. And I know when I've been a peer navigator or worked and been part of the community, it was really hard because I wanted them to know that they were safe. I wanted them to know I was one of theirs. But what ended up happening is I alienated other people. Now, to the term peer navigator, I think that term in itself is stigma. We're hiring folks within because we want them for a multitude of reasons. One, because they know what they're talking about. Two, they're going to be able to understand some things that somebody like me who hasn't used in a long time isn't going to understand. But also we want them to be able to get other jobs. We want them to have jobs that are fulfilling and good for them. If we put that term peer navigator on a resume, we're outing ourselves as somebody who used. We need to come up with language that describes what we're doing or what people are doing in their works, but doesn't out them as sex workers or injection drug users or people who have been incarcerated. And just that term peer navigator does that. Like, we talk service navigators, we talk SSP navigators, something, but just that term peer, people are going to be trapped into an idea for the next place they want to work. And we don't want people feeling trapped. We want to be able to give folks the opportunity to learn Word and Excel and customer service, and if they're interested, accounting, all of that. And all of that can fall into a peer navigator's job description. But when they put peer navigator onto their next resume, it hurts their chances of going forward. Another thing that we tend to do when we are at in exchange is when we talk to people who are going into recovery, it's really natural to be excited for them. But we know that most people do relapse. It's most common. And so when we get excited and say, yay, oh, that's so great, or where are you going? Or I've heard great things, or I've heard horrible things, we're putting our expectations onto them. And so we want to be encouraging without being excited for them, no matter how we feel inside, because we want that person to feel safe coming back. When we overdo it, when we oversell recovery or a treatment program or whatever path they're going to take, we have a tendency to make them feel like they failed if they come back. So trying to find a way to be encouraging without being overly excited, just kind of pulling back that energy a little bit. Okay. On to sex work. So what I have here, this is my only slide, I'm not a big fan of slides, is just terms that are used in sex work. And all of these things can cross each other. All of these things can be, a prostitute can be a dancer, can be a phone sex operator, can be a model, an escort, a call girl. All of these things can cross each other. And I have on there the guy like Johns and pimps as well, because there are people who we might think of as pimps, but who also work, especially when we're looking at homeless youth. A lot of times, male-female dynamics of a couple, the male partner will turn tricks to keep the female partner from having to do it. They're not ever going to identify themselves as a sex worker, especially if there's somebody who's just receiving, like they're getting paid for somebody giving them head. They're not going to see themselves as a sex worker. So when looking at doing testing or talking to people, dropping all of the language associated with work and just talking about the activity. And with this huge rise we're seeing in syphilis within especially the meth community and the sex worker community, talking about just the act, has anybody given you head for money, for drugs, for a place to stay, whatever, totally dropping all references to work, because we want to be able to test people for what they need to be tested for. And sex work is highly stigmatized in our culture. It's becoming less so, I think, in some arenas. When I started dancing, we were horrible people. By the time I stopped, in some places we were kind of rock stars. It was a little weird. And we know we have the porn star love of the 90s, 2000s. So it is changing some, but when people are doing something that society says is bad, they shouldn't be doing it, and they're doing it just so they can pay their rent, pay for food, whatever it is, they're not going to necessarily admit to it. I like the idea of universal testing all sites for everyone, be it oral, anal, vaginal, penile, whatever, on everyone, and just kind of treating it like when we ask people about their race or ethnicity or sexual preferences, just that caveat that we say, we ask everybody all of these questions. We test everybody in all of these sites. It's just for safety. And we don't want, I know tests cost money, we hate spending the money, but just doing universal testing on all sites on everybody, so nobody has to say that they're doing something that they don't want to do. Where language is concerned, again, going back to using the language that folks use. Now, if somebody calls themselves a hooker, I'm most likely not going to use that language, just because I don't want somebody else overhearing it and feeling offended. But talking to people, using the language where they come from, testing everyone everywhere, asking everyone the exact same questions, and using language that is accessible but isn't talking down to anybody. We don't mean to talk down by any stretch of the imagination. We know our clients are smart, but still just cross the board, finding that middle ground. And if you feel like somebody's not understanding, change the way you're talking. If you feel like somebody's toning out because they know everything you're saying, change the language. It's just being really cognizant of who you're in front of. We're all here because we got a lot of heart and we want to help. And we learn from listening. And so listening to our clients and listening to the language that they use. And, you know, if you're confused by something, they're using language that you're not understanding, and you feel like you can ask them, of course, ask them. If you can't, go to one of your coworkers or go to a client that you know really well and you know you have a relationship with that you know you can ask. So finding the avenues to educate and just checking in and using the language that is right there in front of you that the folks are using. All right, that's my spiel.
Thank you so much, Libby. That was fantastic. Very inspiring way to end the presentations, I believe. Kirsten, did you have something that you wanted to close on? Oops, I see more slides here. Sorry, I'm going to share my screen again.
Yeah, no problem. I think there was just the one more slide, and then our contact details. But this slide is, so just wanted to note that so me and Libby, we're doing this presentation through the Harm Reduction Technical Assistance Center. It's a CDC funded TA center, and we provide free help to anyone in the country providing or planning to provide harm reduction services. And we can define harm reduction pretty broadly. So that could be syringe services programs, health departments, programs providing substance use disorder treatment or recovery services. I think people working in sexual health are doing harm reduction all the time, actually. So please get in touch if you have more questions or want to talk, in more depth about the challenges you're facing. We are at Drug User Health TA at NASTAD.org. I can also put that in the chat. But just wanted to note that additional assistance and resources are available. Thanks. And then the next one is just our contact info in case people want that. And back to you, Talia.
Perfect. Thank you so much, Kirsten. I did see we had a few questions about starting a harm reduction clinic or coalition or incorporating harm reduction into existing programs. And I know that the Harm Reduction TA Center would be much better equipped to set up a much more in-depth meeting with these folks. So I definitely encourage you all to reach out to them. But I don't know if you have anything, Kirsten or Ria or Libby, that you want to highlight quickly on the call. Or any best practices or ideas or just places to start to get people thinking about how to incorporate some of these ideas into their work.
Yeah, I mean, definitely a longer conversation for sure. A couple things I'd note is that a lot of communities, even if they don't have syringe access, are probably doing overdose response and naloxone distribution. So maybe find out who's doing that and where that funding is from and try to partner with those programs. If there are other syringe services programs in your area, then definitely reach out to them. They probably have a lot of, hard fought experience and wisdom to share. There are a few national listservs that, some of us belong to where we exchange questions and advice about starting SSPs. I'd be happy to connect you if you want to get in touch to those kind of communication networks. There is a resource, it's called the SSP Technical Package that we put out with the CDC last year that goes through some kind of essential best practices. So I can also put that link in the chat. It looks different in every place, and there may be some allies that are surprising that you hadn't thought about. So I think trying to find people doing overdose work, connecting with any SSPs that exist already, connecting maybe with your healthcare for the homeless or other FQHCs that might be doing like Suboxone or buprenorphine substance use treatment or Hep C treatment. Yeah, Ria or Libby, anything to add?
Actually, I'm glad that this question came up because I meant to mention it while I was talking. I think all of your suggestions were great, Kirsten. but one of the things I think is, creating more opportunities for people to actually engage with treatment. So if, being able to provide medication-assisted treatment, if you're a clinic, if people are coming in to access reproductive health care, being able to say, hey, you can actually get your script for Suboxone here too. I think I don't think you necessarily have to start building a harm reduction program. You likely probably already have the components of one existing where you are. It's just integrating some of those services into your organization. Now. But I think, familiarizing yourself with the community, knowing what the needs of the community are, and getting to know people who are doing the work is super important. And asking and making sure that when and if you do build something, that you're actually centering and asking folks about the services that they need, instead of just creating something because you think that there's a need for it.
I have one thing I forgot. Can you guys hear me? Sorry, I'm having so many computer problems.
Yep, we can hear you.
Okay. I wanted to address really, really fast the term survival sex work. It paints a picture for us. I get that, but don't we all work to survive? Isn't it survival retail, survival fast food, survival social work? Anyone who's done social work is raising their hand right now to yes to that. Again, stop with the language, look at the behavior. Survival versus, are you surviving or are you thriving? Screw it. They're working. It's a job. Let's just make it safer. I don't the term survival just puts them at that base level. You are at this base. You are just surviving. Lots of jobs have aspects that suck and aspects that rock, and it can be the same job. There are baristas who should be strippers, strippers who should be baristas, yada, yada, yada. But when you're using that term, I get it. It paints a picture for us, but it's not painting a picture of that person's actual life.
Thank you for that addition, Libby. I think we have time for one last question. And while it's for Ria, so while Ria is responding, I'm also going to launch a quick poll just to get some feedback on today's presentation. But somebody is saying that they're curious about the reproductive harm framework and whether there have been conversations about how that framework could center traditional harm reduction and other aspects of reproductive justice, like minimizing the harms associated with the institutional racism or sexism in the medical industry.
I'm so glad you asked. So this framework is something that I've been working on a project with the Urban Survivors Union, which is the National Drug Users Union, working on a project called the Narcofeminism Story Share. And it's basically utilizing personal narrative as a way to interrogate bias, and it's basically a stigma and bias training for clinicians. And so, we're sort of just kind of conceptualizing what this means and what this looks like, because we did see, in doing this work, perinatal harm reduction is a fairly new thing. There have not been a lot of spaces centering the experiences of pregnant people who use drugs, largely because the harm reduction movement, many social justice movements, were taken up with a lot of space of cis white men. And so there just wasn't a whole lot of conversation around the integration of harm reduction and reproductive health. And I think too, again, as even drug users themselves have a lot of stigma and bias around, and their own feelings around pregnancy and drug use. And so most people were largely and still are largely ill-informed and quite frankly ignorant around the impacts of substance use on pregnancy. So to answer your question, we are actively wanting to recruit and build our networks, and we are working with Tina Reynolds, who I'm not sure if anyone's familiar with Tina, but she's done a lot of work within the criminal justice world and the reproductive justice world, and so we're thrilled to have her and be working with her. And so yeah, I mean, I think both of those, and like I said, the reproductive justice movement, there's been a lot of harm that has been done by the medical industrial complex to people, to communities of color. And so it's sort of like getting together and thinking about this integration and how that can translate into building a more robust movement on both sides, because really harm reduction, reproductive health care is harm reduction at its like fundamental, at its core. So I don't know if that answers your question, but if you're interested in getting involved, shoot me an email.
Yes, absolutely. It looks like we have quite a few people that are interested in this ongoing project. So very excited to continue to hear about it. And with that, I just want to lead everybody in giving a huge, huge thank you to all of our presenters today. That was such a fantastic webinar. And I know I learned a lot, and I'm sure other folks did as well. So thank you again to Kirsten, Rhea, and Libby for taking the time to join us today. And yeah, feel free to email any of our presenters with any follow-up questions, and I will be sending out the recording to all registrants as well later this week. All right, well, I hope everybody enjoys the rest of their Tuesday, and I will be in touch soon. Thanks again, everyone.
Thanks,
Thank you.
Talia. Yeah, thanks, Libby and Rhea, and to everyone who showed up and was so engaged.
Thank you
guys.
everyone so much.
All right, bye, everyone.